A little bit about Médecins Sans Frontières. So just for the audience, a little bit in numbers. So you employ 67,000 people worldwide, and most of those people are local people employed for Médecins Sans Frontières. You have 7 million donors worldwide, and 98% of your money comes from private donations. So me, this is what a common humanity looks like. I think this is incredible. So you became president then this year, just in September.
Yep.
So, but as Adam indicated, you know, in 2024, you were a medical team leader in Gaza. Mm. So let's start off talking about this. So your experience there. So what is a medical team leader? What is your role in that position?
Yes, a medical team leader. Well, firstly, thank you for having me. It's a real pleasure to be here, and it's been fascinating all day. A medical team leader is a little bit what it says on the tin. So at project level, down, you know, by the patients, you're the team lead for all the medical operations. And what's not medical is the logistics, the administration, finance, and HR, and of course the operations. And the operations really looks at security and representation. So you're the team leader, and depending on what the project is, you'll have the medical managers and be bringing them together to deliver the objectives of the project. So, for example, in Gaza, I was over 3 projects. One was a trauma, so orthopedic trauma and burns unit inside the Ministry of Health hospital called Nasser in Khan Yunis. But also we had 2 primary healthcare centers and also water distribution. So in that sense, I had a water manager, surgeons, medics, nurses, physiotherapists, occupational therapists, mental health, activity managers, and I would be their team lead just to make sure that we can do what we need to do.
And but in this doing what you need to do in such an extreme environment, I mean, particularly the medical community were under attack. How did you manage to work? How did you cope in this?
Yes, I mean, you know, Gaza, we characterize Gaza as a genocide, right? And it's contextualized within the wider occupation of Palestine. One feature of that genocide for us is the systematic dismantling of the healthcare system there. And that was characterized in several different ways. And what we saw were not only the direct attacks on hospitals and even medical convoys, but also closures of hospitals. So when there is a displacement order, an order to leave an area, the hospital has to close, the whole population goes. So just in the 2 years that we've been there have been 24 medical facilities that we've had to leave. So that's sort of the infrastructure closure. But then what's a feature that I hadn't seen previously quite so much is this sort of very intentional attack on healthcare workers. So there have been over 1,700 healthcare workers killed in Gaza since the beginning, since October 7th. And we've had 15 colleagues, MSF colleagues, some killed at work and others killed just because of the sheer level of violence. But the feature here that's quite so worrying is the very deliberate targeting, detention, and even torturing of healthcare workers simply for doing what they do. So my colleagues said at checkpoints, whenever they were moved from the north to the south, if there was any sign that you were a medic, they'd been pulled out and then detained, questioned, some for many months. Many were beaten. The orthopedic surgeon that I was working with still had a limp from his detention when he had been detained at Shifa Hospital.
And so how is Médecins Sans Frontières dealing with this, you know, as an organization, this unimaginable situation?
I mean, for us, you know, we concentrate on bringing about care in the best way that you can. Right now, coming into winter with the ceasefire that's very fragile with ongoing violence, our main concern is that we haven't seen the huge amount of increase in aid that we were expecting. So food, water, shelter is still a big need. And you know, my colleagues are living through this. I had the enormous privilege of going in for 2 months and knowing that I would leave. But my colleagues are still there. They're living through this. And of course, the threat of violence and disease is all round. So in that sense, I think what I always do and with my teams is just really focus. What can we do more? What can we do better? Think about those little moments of care that you bring and healing to each patient and try and facilitate it for them. But that can be hard in a situation of a supply blockade where you're reaching for your second or third line drug, or you didn't have crutches or wheelchairs and you've got so many amputees. Or it's impossible.
And it is impossible. It's even hard to imagine. Yet, after Gaza, up until February this year, you were in Sudan, and which the UN says is the biggest humanitarian crisis on the planet. It's bigger than Gaza. There's more deaths than Gaza, twice as many, I think, 150,000 people killed, many million displaced. And what is this experience like, and how is Médecins Sans Frontières coping with dealing with this?
Sudan presents really profound difficulties, not only in the sheer scale. So it is the biggest humanitarian disaster in terms of numbers of displaced, numbers of killed, numbers at risk of people. You're in the tens of millions here. What happened in Sudan, and I'm half Sudanese, was a total implosion of the state overnight and general warfare. One characteristic of this war is attacks on civilians, attacks on civilian infrastructure, attacks on healthcare, and it's very difficult to work on both sides of the lines. You've got two warring parties controlling their own territories, and they see. And they create blockades and make it very hard for us to move supplies, to move staff. You need a permit for everything. And in that way, it creates a control that shouldn't be there. Humanitarian aid, whether it's Gaza or Sudan, shouldn't be conditioned on anything. It's something that needs to get to the population. It's independent, it's neutral. It mustn't be treated as a bargaining chip.
And you're doing this in the context of huge amounts of funding being pulled at the US and other countries, reducing aid funding, development funding. There was a Lancet report a few months ago now, estimating about 14 million people by 2030 could die because of this pull back from funding. Many uncertainties in those numbers. How is Médecins Sans Frontières coping with that? Then you can't.
We can't fill the gaps. We're not directly impacted by that. So we're independent, as you mentioned earlier, with all our donors in terms of our funding. But when you work in a health ecosystem and the actors around you are falling away, then it has a profound impact. So on one side, it's costing us more to do the same, and on another side, we have to do more. And an example there I can give is while I was in Sudan, the cuts that had been announced meant that, and I was working in Omdurman in Khartoum, and we were doing trauma inside an emergency room, but also pediatrics and cholera and vaccination. But overnight, 3 different organizations came to me saying, can you help? And one of them was an emergency room giving food, an emergency response room, the ERRs of Sudan, was actually giving food in the hospital. They'd lost their funding. Another was a Sudanese network that had funding from a US agency to do community sexual and reproductive health. So a community network of midwives just fell away. And in a context where there is sexual violence as a weapon of war, that's an issue. And so there really is a maternal and child health sort of emergency in Sudan. So when sexual and reproductive health fell away overnight in the city, that was a problem. And we can flex, but to fundamentally change our program overnight was not something I could do. So I could support as much as possible. But other examples are that, for example, with malnutrition, even now this year in Yemen and Niger, for example, we've had to put in unplanned provision for malnutrition, something that hadn't been provisioned or planned in the beginning of the year, but we pivoted and do that. So then we're doing more than we expected. That's okay. We always keep buffers of funding in our unplanned pot. You never know when an emergency is going to start. But we have to be clear, there's no way that one organization, MSF, can fill the gap left behind by so many countries abandoning their international donations and their sort of commitments for global health and humanitarian action.
No. Now, we're going to invite some more panelists and then and discuss this idea of from bench to bedside, because and with Médecins Sans Frontières as sort of the extreme in some ways, extreme environments for providing healthcare. So I'd like to invite on stage Jan Nielsen and Maya Fjastad and Sally Davis.
An extra chair? Oh, right, so I should stay on this one then.
Oh, there we go.
There's an order.
Musical chairs.
Here we go. Good.
To get there in the end. All right, so it's a gender division. So interesting. Well,
yes, there is a bit.
Oh, well.
And colour also, yes.
Maybe just to bridge this as well, this conversation. So on that, the bedside on treatment, Javid, you do a lot of innovation within Médecins Sans Frontières. You have like mechanisms internally to sort of create new innovations and speed up that process between research and treatment.
Absolutely, yes. I mean, we have internally what's called the Access Fund, and that's precisely actually based on some of the things we've been talking about in earlier panels. So looking at drug development, drug pricing, access to medicines was the fuller name, and it's to assure that lower income countries and neglected populations can have access to medicines that the richer nations do. And actually, interestingly, our Peace Prize fund in 1999, I mean, that's the reason MSF is here, we're sort of Nobel laureates in that sense. We committed some of that money to starting an organization called the Drugs for Neglected Diseases Initiative, DNDI, and it does exactly that. It develops in a non-profit model medicines for neglected diseases. And I remember visiting in the DRC in Congo a clinical research trial that was literally a short flight over the jungle, half a day's drive to the town, and then you take a motorcycle at 5 a.m., couple of hours through the jungle again, and then onto a canoe, and that was about 3 hours down to the community. And there you're doing lumbar punctures to check on these people to see if they have sleeping sickness. And if they did, you have to bring them all the way back to the hospital. And that's not for a 3-week inpatient treatment that killed 1 in 5, and it was arsenic-based. So that's not a viable treatment for a disease. And DNDI MSF did this clinical research and have been able to bring forward an oral treatment for sleeping sickness, and it's just revolutionized that. And it's affordable and easy to store, easy to deliver. And so that's an example that it can be done.
Mm. Good, and then this is good to bring you in, Jan, because are we doing enough to do that translational work in least developed economies, in least developed countries? I mean, so much of the work is happening in the developed world, and emerging economies could be losing out.
Yes, no, we're not doing that at all. It really struck me. Last year we had a Nobel Symposium on cardiovascular disease in South Africa. And we had the leading scientists there, and we were discussing the latest diagnostics and molecular diagnostics and new treatments based on RNA. And then we had one day just focused on cardiovascular disease in Africa. And it was only with African scientists that they said, well, it's all very interesting, but it doesn't really help us anything. We have a public health problem. In Soweto, 50% of the women are obese. They all are developing hypertension and they're suffering from diabetes and stroke. And if we try to convince them about public health, they don't listen to us. They listen to the village witch doctor. Mm. And our governments are so busy with corruption, war, and so that they're not really paying attention to the public issues. So we would like you, and ourselves, they were really saying, we have to solve these problems. It's not something that you would do, but it's something completely different from what we're doing in science in the developed countries.
And Sally, do you have a thought on this as well, on this translational to emerging economies and developing countries?
So I think it is very difficult to take high tech and dump it in a low income country. Can they afford it? Can they run it? Do they want it? Was it a priority? I set up in 2020 an NGO called the Trinity Challenge, and we've gone about it by mission-driven. Here's a problem. Bid in if you want the prize for how you would solve it using local tech. 85% of the solutions have AI and machine learning, but it's locally that they've worked out what to do, how to do it better. The winner the first time was a Thai winner who's turned farmers. This one was about AMR. If I'm involved, that's often there. But it turned farmers into disease detectives using their mobile phones and a central vet. And it's really helped their local economies. So doing things locally and letting them solve their own problems, which I think is part of yours. But you can extend that into the high-income countries. So what I used to be famous for was that I persuaded our government in 2006 to let me launch the National Institute of Health Research, NIHR, which was there to fund clinical, applied and policy research. And the whole concept behind it was that no one was funding that properly. We had to keep the basic and experimental, but we needed this. And that if people got their hands dirty and joined in the clinical studies, then once they got the results, they were much more likely to put them into practice. So it was a way of getting more research done, but it was also a way of improving the standards of care so that they were modern in our NHS hospitals and primary care.
And it's a huge success. I mean, so over 1.2 billion funding each year now. And can you give some examples of the kind of things that have come from it that wouldn't have come without?
A study that showed that you only needed, as a woman with a certain time of breast cancer, 3 visits for radiotherapy instead of 12. In COVID, all the recovery trials, one of the parts of NIHR that I set up was I took away all the research funding that was in the NHS, put it together, and instead of having clinical trials networks that were based on just friends meeting, we developed managed clinical trials networks where the nurses, the data collectors, everyone was trained in what their role was, how to do it. We would only put into our managed clinical network that was in 99% of hospitals trials and studies that had gone through ethics committee and were properly powered and properly constructed, and then we could run them really effectively. And during COVID, that's why we were able to prove very quickly that high-dose steroids had an impact, that many of the things that Trump thought up caused harm and didn't work, and then to try out the actual drugs. We've got a vaccine part of it that did a lot of the challenge studies and everything. So we've got lots of good examples.
Good. And then, so on COVID then, Maya, I'm going to turn to you. I mean, you were Secretary of State for Health during the COVID crisis here in Sweden.
You had to remind me about that, did you?
And you've written a book about it, At the Center of the Crisis. And it was an absolute unique moment. And it changed a lot of things. When we talk about from bench to bedside, all along the chain, it revolutionized many, many things and accelerated many things. But can you talk through that period of decision-making and stress that it must have been to change a whole system to respond to this pandemic?
Don't bring me back. But I think when we're speaking about from bench to bedside, I would say that COVID was really a triumph of the professions, really, because it did go quickly from bench to bedside. I mean, we did implement new protocols for treatment. I mean, of course, the vaccines is one part of it, but the treatments were changed quickly. We phased out chlorotinin quickly when we realized that was not a good way of treating patients. And when I speak to professions that work during COVID, they often feel that they were allowed to make decisions that should be the decisions of the professions during this time. But on the other hand, they often describe that nobody listened to their experiences afterhand, and that's something we also work at Karolinska Institute to actually. I mean, we put so much resources into COVID. We could put resources into collecting lessons learned, right? And so many people working in healthcare did incredible things during very chaotic circumstances, and we need to collect their lessons. But I think on your other question on sort of the science to policy during COVID, I think that was something I struggled with. And some people asked me about, you have a PhD, it must have been much easier for you. Well, my PhD is not in infection medicine, so that didn't help so much. I think the only thing that helped was that to have a PhD made me a little bit less respectful towards researchers. I mean, I don't hesitate to call a researcher if I need an answer or something, and that's sometimes great. Sometimes you end up with the wrong researcher, and then you have to ask someone else. But I think that's been something I've been reflecting a lot about after the pandemic. How can we actually put in place a good system for science to policy or evidence-based policy? Because I did struggle with that.
And maybe say a little bit more on this struggling, because it's making decisions under extreme uncertainty and that constantly changing, and having to make some judgments about how the public are going to respond to those decisions, etc. So how did that go? And Sweden took a very different route in some ways than other countries. Can you say a little on that?
Well, we did. There was I would describe it as a political decision, but also as a natural consequence of our public administration and about our contagious matter law, that we wanted to listen very closely to the public health agency and to listen to the experts, and that made us difficult. I mean, there were other countries where the politicians made one decision and the public health agency did one, but we didn't really have that opportunity, luckily, I think, personally, because I think it was important to stay close to the agency. But there's, of course, a discussion that I think is interesting if politicians use experts to sort of delegate responsibility. I mean, the democratic responsibility must always be to the politicians. You can never say that, but the agency said that. I mean, that has to be a decision taken within a democratic system, because the responsibility must also be possible to demand within the political or democratic system.
Mm. And
I wanted to come in because I was, when I was setting up the National Institute for Health Research, I was the chief scientific advisor at the Department of Health. And then I became the chief medical officer. And I stopped talking about evidence-based policy. What I aimed for was evidence-informed policy, because I recognized the democratic right of the ministers to take a decision. Mm. My job was to try and make sure they knew all the bits. I would often, if asked, tell them what I would do if I was them. But I wasn't them. Mm. And they brought other things to the table to make those decisions. Mm.
And Jan, I mean, you think there were some amazing innovations, from bench to bedside during COVID, but we were at risk of ignoring them or forgetting about them.
I think it was an interesting experience because, as Maja said, the decision-making went down to the professionals. And it turned out to be effective, and the working environment was much more stimulating. So people really liked working, even though it was tough work. They really liked it. And the interesting thing, that's the way it used to be. If you go back to the 70s and 80s, the professionals were running the thing. Unfortunately, they didn't care about the budget that much. So something had to be done. And then came, I'm sure you heard of new public management, all of you. So there were managers taking care of healthcare, and these focused more or less entirely on healthcare, of course. And the universities, increasing competitiveness, wanted to go for the big funds, which was more on the molecular side. So the clinical research just disappeared. And that's so dangerous because if the really new discoveries is going to come to benefit of patients, we need a translation, of course, and that's clinical research. And we have to find a way back again where we can work together, healthcare and university. And I think you did a fantastic initiative in forming the National Institute of Health Research. And we have to find similar ways. We can't do it the same way because, no, we have countries taking care of healthcare and government taking care. But I think the way you did it is a great inspiration to others.
Thank you.
And Javid, with Médecins Sans Frontières, how was COVID dealt with in those sort of humanitarian crises in that sort of area, and sort of retraining, rethinking, and just managing that sort of bedside treatment in that kind of environment? What were the learnings?
It was a profound shock, obviously, to everyone. I mean, I was working in the UK health service through COVID because I was stuck. Right? There were no flights out. And we have teams that turn over, we have supply lines that, not quite just in time, but you know, they are quarterly. And so when you have a 2-year blockage of supply lines, that creates a real problem. And so for us, the issues were really structural in just carrying on. We took the outlook very early that this is bigger than us. We're not going to be able to respond to a pandemic in every region, in every country. So our outlook was preserve the life-saving we're doing already, which is critical in many of the places that we work. And that was very hard. So we had staff who, if they were on 6-month rotations, the international staff that come in and go out, stayed in projects for a very, very long time. Supplies, and of course then there were issues around, then in places where we were expecting a high burden of disease, what operational response can we and should we make? And we did do that. And actually it ended up being in Europe, in sort of vulnerable or marginalized populations. So we ended up doing COVID care for homeless people in the UK, or for the elderly in Belgium, in care homes, and France. And that was also new for us because we're quite used to the field being over there, and it being in Europe, again, was a little bit sort of, we haven't done this before, these sort of medical operations. So yeah, in many different ways, it provided us with difficulties and challenges that we hadn't met before. Not least that our three main, we do all our logistics in-house. Everything that we move, goods, supplies, is done, we do it by ourselves. But our 3 main logistics centers were in Europe. And so when Europe was shut down, that created its own issues. So even on that basic level, learning has been to diversify our supply chains and lines, and even look for local procurement in ways that we would not, because of you've mentioned earlier today, Sally, the assurance of drugs. I mean, if you're buying antibiotics locally, you don't know where that's from. We had very strict rules to not do that. But in a situation where we couldn't move supplies out, we had to make trade-offs.
Yeah. Okay. So, well, looking forward, Sally, what do you think are the sort of cultural and structural changes needed? You know, learnings from the institute in the UK and beyond, to really embed, to sort of accelerate this gap, or this from the research to treatment.
Well, I think what doctors, at least in Britain, and I think generally are very bad at, is taking things from outside a supermarket. You do something that way, it works, you scale it. So I think we need to start much younger with our medical staff and our nursing staff and pharmacists, saying, join in research so that you understand it, you get a feel for it, and you want to put it into practice, but then look at what's going on elsewhere and pull it in. You know, be absorptive. We don't all have to do the research. Let's change to a behavior that's absorptive and ever improving and as frugal as possible.
And what do you mean by absorptive?
Well, it's a business term, isn't it? That you don't just go on doing what you always did. You see that someone else is doing it differently, and you evaluate or think about anyway, is it better? And then you start doing it if you think it is.
Right.
So
Like an innovation.
absorbing from elsewhere their learnings so that you really keep up to date.
And you really need a culture of innovation in organisations to be able to do that.
That's a much better way of saying it. Thank you.
But it's like, how do you create that kind of culture of innovation, I suppose?
And you have to make it fun, and you have to give people enough money, and you have to trust them. And I think Jan and I probably agree that the present health systems don't really trust the doctors enough.
So how, Maya, any thoughts? How do we, how can we create these governance systems for innovation, do you think, in the medical system all the way through?
Oh, that's a tricky question. I'm also reflecting actually on, I mean, the implementation side that we're all discussing here. I think that sometimes suffers actually from a bit of paternalism. And I mean, we were discussing this earlier during the day, that why do people go to McDonald's? We told them that it's not healthy. They keep doing it. And why do people not take vaccines? We told them it's good for them. And I think that there's amount of danger actually to have this attitude from both, you know, political side and the medical side, because sometimes we don't realize that, you know, it's not a conflict between enlightenment and stupidity. It's a social conflict. It's the reason that people don't take vaccines is that they don't trust government, and sometimes it's actually rational not to trust government if we look at history. So I think that we need a little bit of be a little bit humble also when we approach the implementation of both medical inventions and other inventions.
Well, then that is a good moment to end on the humbleness of the research community in this. So I'd just like to thank our panelists so much for joining us today. A big round of applause.